This is a download from BFM 89.9, the business station.
Good afternoon. Welcome to Health and Living. I'm T. Xiao Ik. It's Friday today and... Sorry, a bit of problem with the mic there. It's Friday today and it's the Doctor in the House show, and today we're talking about rehabilitation medicine. But first, as always, for our Doctor in the House segment is Dr. George Lee, consultant urologist. How are you, George? Oops, George is...
Can't hear.
Sorry. All right, George, have we lost you already? The show hasn't started, we've lost you. George, stop talking. We can't get you. But anyway, we'll let George sort out his mic issues. Meanwhile, we also have Dr. Lydia, Chief Medical Officer of ReGen Rehab Hospital, joining us on this show. And we are talking about rehab medicine because Malaysia is facing several important health crises. And right now, all we can talk about is the COVID-19 pandemic. But really, we have been for many decades facing the increasing incidence of chronic non-communicable diseases. We're also looking at an aging population in Malaysia. And so the reason we want to talk about rehabilitation medicine today is because it is very critical to help patients regain their function following, things like injuries, surgeries, and disabling medical conditions. Together with George, we'll be speaking to Dr. Lydia to find out more about how the role of rehab medicine in our health system, how it plays a role in our health system, as well as how to enhance the delivery of these services to our population. Good afternoon, Dr. Lydia. Thanks for joining us. How are you?
I'm fine, Xiao. Thank you so much for having me on this show today.
Yes. If any of you listening have any questions for Dr. Lydia, do WhatsApp us. As always, our lines are open, 018-789-8899. You can also tweet us at BFM Radio. First, Dr. Lydia, what is, perhaps you can help us to understand, what is this term rehabilitation in the context of healthcare, and what does the discipline of rehab medicine cover?
Okay. All right. So simply to put it, rehabilitation is actually a process of helping a person to restore their function. So it is actually a set of intervention that we do and apply to patient. And in the context of healthcare, rehabilitation is actually an essential component of universal health, along with the other components like health promotion, prevention, and treatment. Okay, so you can say that rehabilitation is a critical component of the continuum of health care. And the discipline of rehabilitation medicine, we are like the late bloomers of medicine. Okay, so it is a branch of medicine. We are medical doctors who specialize in this field, and our field is concerned with prevention, diagnosis, treatment, and rehabilitation management of any person who gets disabled following illnesses or injuries.
Okay, I'm going to try and check if we have George back. George, would you like to try speaking? Nope. We still haven't got him. This is technology for you, isn't it? George, if you are able to join, do jump into the conversation. But I'll continue with Dr. Lydia. And so, Dr. Lydia, the term rehab, how is it distinct from physiotherapy and occupational therapy, things like that?
Okay. So rehabilitation medicine is, like I said, is a specialty of its own. Right? And physiotherapy and occupational therapy, they are also healthcare professional, and they are also very involved in rehabilitation. So as a rehab physician, we deal with the medical needs of the rehabilitation patient, whereas the physiotherapy, they are involved in the physical and training aspect of the patient. Mm-hmm. The occupational therapy, they deal with the activities of daily living and functional aspect of the patient. So together, we are the rehabilitation medicine team, that treats the patient.
I see.
So in actual fact, there is no identity crisis, but I think because it is quite synonym, when people say rehabilitation, they immediately relate it to a physiotherapist.
So rehab medicine being the larger umbrella that various therapists would come under, or that you would work with.
Yes, in a way, it's an umbrella where there are different components that delivers the service to the patient.
And I'm going to try George again. I'm very optimistic.
Okay.
George, are you
We
there?
are hearing you, George.
Third time lucky. Can you hear
Yes,
Okay.
we've got George back
got
on.
it, George.
All
Yeah,
right.
this is going to be a sunny Friday now. So, Dr. Lydia, from the perspective of a patient, what would I want to achieve in rehab medicine?
Okay, so to pick it for the patient, yeah, the main objective of rehabilitation is to help them to restore their function, to promote their recovery much faster, and of course to prevent complication.
Okay. And I suppose complications would depend on what particular condition that you are addressing in that individual patient. So perhaps it's something we can go into later if I ask you to perhaps give some examples of the more common conditions that you work with. George, anything you'd like to share at this point? I know I've left you out so far.
No, it's all been concise, and I'm looking forward to hearing what sort of patient load we have and what is the setting in Malaysian kind of environment.
Patient load, yes, because as I said in the introduction earlier, I mean, the main issues that concern us today is non-communicable diseases, but that itself is a broad term that covers things like stroke, heart disease, and those are already among the two conditions that where rehab medicine is required to step in. But Dr. Lydia, could you give us an idea of what kinds of conditions would require treatment through rehab medicine?
Okay, so rehab medicine, we cover quite a large number of disabling condition, and it can be broadly divided into four main areas. All right. So the first one would be any conditions that is related to the brain, to the nerve, that we term it as neuro rehabilitation. So in this category of neuro rehabilitation, we treat cases like stroke, which is one of the most common condition in our society, brain injury, Parkinson, spinal cord injury, post-coma patient. All right, so that's number one. The second category is patient who falls into the musculoskeletal group, and these are the group that requires very fast kind of rehab. This will be the orthopedic based kind of condition, arthritic patient who has undergone joint replacement, sports injury, chronic pain, amputation. Okay. The third category would be general medical. This would be mainly patients from the geriatric population, the elderly patient, cardiac patient, for example, post-cardiac event, post-stenting, and what is becoming more important now is cancer survivors. What we term as oncology rehabilitation is really gaining its momentum. Patient who suffers from chronic pain, and the last category would fall under the regenerative area, whereby we want to try to promote healthy aging, a little bit more on the cellular-based therapy, try to give a little bit of wellness into the patient as part of the prevention of further worsening of their condition. So
Wow.
this is the broad category of patients. So at any one time, you can say that anybody may need rehabilitation at some point in time in their life.
Can you give me a little bit of more details on the regenerative medicine part, Dr. Lydia? That's something quite new to me.
Okay, so regenerative is, it depends. Basically, it falls into, if I were to explain it, you can treat patient, or it can also be a prevention. That means preventing disease. Okay, so let me take you through regenerative in a patient setting. All right, so that means if you have got an illness right? Which at this point in time, conservative treatment or Western treatment is not giving very satisfactory kind of improvement. For example, the patient has got spinal cord injury and they are having paralyzed, they're paraplegic, right? So which means that whatever that we have been doing has not been able to restore the function. So regenerative is quite a new approach. Yeah, it uses a different modality of treatment. One of it is biological treatment. Secondly, is using cellular-based therapy. So these are relatively new, yeah, to the concept of treating patient. To some extent, it can also be controversial because we are using a different way of treating patient. There is not much evidence yet out there, yeah. Hence, you can't really say that it can be used in the guidelines to treat the patient. But there are pockets of research that being done, and you can look at some of the studies to see whether this sort of treatment is suitable for such patient. Okay, so this is like using cellular-based therapy.
Does that include stem cell treatment?
Yes, it does
I
use
see.
a stem cell.
Right. So, like you said, still very much experimental.
It
A
is
lot
very
of
much
it.
experimental, yeah.
All right.
I mean, shall we? I quite like to ask. Obviously, that is a very exciting forefront of medicine that we're pushing forward. I mean, with yourself describing so many patients already involved, for example, neuromuscular patients, stroke patients, and also medical patients. What sort of number of patients get involved with this regeneration medicine?
Okay. Not very much, because the prohibiting factors would actually be the cost, because the technology is not readily available. So it is still a very costly affair. So this is one of the reasons that really prohibits patients from getting regenerative kind of treatment.
Dr. Lydia, can you give an example of the last patient that underwent regenerative therapy?
Okay, so we had a patient who had his in the mid his age is about 60 plus. He had a fall about a year before he came actually to us. It was just a trivial fall, but because he had a background of an aging spine, so that led to a spinal cord injury. So because of that, he had quite a significant, not just paraplegic, he actually had quadriplegic, which means that all the limbs, upper limb and lower limb, he cannot use. He loses completely the voluntary movement of the arm. So he had treatment, he had surgery, he had treatment. He came to rehabilitation pretty late, almost about a year down the line, because of various reasons. And when he came to us, we did what we had to do. But because of the condition of the spinal cord itself, which is a C5 lesion, so we know that the prognosis is not so great. Yeah. However, because he was very optimistic, but one thing you have to understand, we don't really promote it all out, but we do give the option for the patient, and they are free to explore this option. So after he found out about this stem cell, and he was keen to try, so he actually tried having this treatment.
All right. Well, the bulk, I guess, of rehab medicine, we are still talking about addressing the neurological conditions, the musculoskeletal that you raised earlier, Dr. Lydia. So let's look at that within the context of perhaps something...
Just let me put things in perspective again. Though I did mention about regenerative, but it doesn't substitute the physical aspect of the treatment. So those things is still relevant and is still much needed for the patient. So regenerative is like an add-on. to their restorative approach.
So let's, we'll go for a quick break now, but when we come back, let's look at it from something like stroke, which is so common in Malaysia, on the increase as well. And if you could walk us through the process of how you work with the patient and with the other specialties in the patient's overall management of the condition.
Sure.
So on the line with me, Dr. George Lee, consultant urologist for our Doctor in-House segment, who's finally got his mic working, and Dr. Lydia Abdul Latif, Chief Medical Officer from ReGen Rehab Hospital. Stay tuned, we'll be right back, BFM 89.9. Welcome back to Health and Living with me, T. Xiao Ik. It's our Doctor in-House segment today. I have joining me consultant urologist Dr. George Lee, as well as Dr. Lydia Abdul Latif, Chief Medical Officer of ReGen Rehab Hospital. We're talking about the role of rehab medicine in our healthcare system, in helping our society, which is really facing huge numbers of chronic NCDs, or non-communicable diseases. We're talking about aging issues. We're talking about very high cases of road accident injuries. And so all of this and many more, rehab medicine has a role to play in these conditions. If you have any questions, do WhatsApp 018-789-8899 or tweet us at BFM Radio. And we do have a question here from RJ, who wants to know, is spine surgery under musculoskeletal rehab or neurological rehab, Dr. Lydia?
It can be both, but the bigger umbrella is actually neurological rehab.
And in any case, again, it depends on what the underlying condition and the root cause of it is that you're trying to address.
That's right.
Yes. You talked about the objective of rehab medicine for a patient is really to return to recover your function, to return to function. And it seems like very much a basic common sense idea, isn't it? That's what every individual would want. But if you can put it in the context of their overall recovery and why it's so important to make sure that you don't miss out this aspect of their function.
Okay, so let's take an example of a stroke patient, right? Because a stroke patient is pretty common. So firstly, we work very closely with other doctors, like urologists, like George. We get referrals from urologists, neurologists. So for example, a stroke patient, during the acute period, they will be treated by the neurologist. And during that time, the aim of the treatment would definitely be to do neuroprotection and to ensure that the maintain blood circulation. So after that, the patient would then be referred to us for the continuation of rehabilitation. There is a study that shows that during the early phase of stroke, the patient is very inactive. So this is actually not very good for the recovery of the patient because they delay them in sending them for rehabilitation. What happened to the brain, why rehabilitation is important, is going back to the understanding of the condition itself. So especially for stroke, rehabilitation can make significant difference because what happened to the brain after the neuroprotection and the blood vessel being restored, the next phase is actually what we call a phase of restorative of the brain function. So this is where I would like to introduce the term neuroplasticity. Have you heard of that term before, George? Neuroplasticity?
It means the ability for the nerve to regenerate, right?
Excellent. Yeah. So the lesion itself, the stroke, act as a stimulation for the neuroplasticity mechanism to set on. So it is almost like a brain after a stroke is like a developing brain. That is what the cerebral milieu is being described as, which means that it is actually very sensitive to changes. Okay, and this is where we need to capitalize because the changes that the brain is sensitive to is what we expose or what we give the brain to experience. Okay, because the brain will then learn and adapt. And then that's where the neuroplasticity will cause the changes. So rehabilitation is the set of activities that we will actually provide to the patient to encourage this neuroplasticity. So if we look at stroke rehabilitation, there are many components to it. There is the medical component, the physical component, psychological component, even return to work component. So after we get the referral, we assess the patient. We assess patient in terms of the severity of the stroke, and then for us, we then decide what is the prognosis of the patient, then what is the goal of the patient, because rehabilitation is very goal-driven and outcome-based. Once we are very clear, we know all these things, we set the goals, we get the team on board, then we will prescribe the rehabilitation management. On a weekly basis, we will assess the patient again to see whether he or she do achieve the goal that we set for them. So it is very important after a stroke that they need to get a proper rehabilitation, which is multi-component, professional, goal-driven, and outcome-based. So because like I said, they don't have just a single problem. Usually they will have several problems. They will have problems with their speech. They will have problems with their walking. They will have problems with swallowing. They can even have pain. Like, for example, I had a patient who didn't want to do any rehabilitation because of they have got post-stroke pain, which was not recognized.
George?
Well, from the sound of it, it's quite multifactorial. Depends on, obviously, to start off with, the fitness of the sufferer. And also, on the other hand, the healthcare providers, it has to be a team of multidisciplinary approach to help the patient. I know you mentioned that this is very goal and outcome orientated. I mean, how many people actually achieve the outcome that you set for them?
Okay, so if you look at the stroke patient, if you're talking about mild to moderate stroke, right? For mild stroke, they can actually recover almost 100%. For moderate stroke, if they get the treatment, which is the first 6 months, what we call the golden period, you can actually get up to about 70% who doesn't need to be dependent on anyone for their personal activities of daily living. Of course, you have got the very severe stroke, whereby the lesion is very large, and this group of patients, sometimes, their recovery may be very slow, or they may not recover at all.
All right. Going back to the example of the patient that you mentioned very briefly just now, that she didn't want to do rehab or she couldn't do rehab because of post-stroke pain. Now, how do you address a situation like that?
Okay, so post-stroke pain is actually a valid concern. So what has happened is that this patient, she refuses to do any movement, or she refuses carer handling her because she has got this pain which is called neuropathic pain, which is common after stroke. And she has got what we call allodynia. All right. Are you aware of that, George? Allodynia is actually a painful situation when they are given a non-painful stimulation. So which means that if you are just touching the patient's hand or just rubbing it or stroking it, it's not supposed to be painful. But this patient has excruciating pain, and people thought that she was just losing her mind because, she was just complaining. But it's actually a valid condition, and people don't see enough of it, will not recognize it. So when she came to us, we recognized that she has got allodynia. So we addressed the pain. And after she was started on pain management, she managed to get the rehab done. And she's one of those with moderate stroke, which means that she had 60% of recovery, if she actually do the ritual of rehabilitation.
So, in that situation, you had to address one other aspect of her condition first before you could go into a rehab program that would suit her. But, overall, when does the rehab physician come into the picture?
Okay, so as soon as possible. So the referring doctor would actually make the call, and they know that once the patient is medically stable, then they will actually refer the patient to us. Yeah, and they have to be medically stable because going through rehab is like going through a fitness class. Yeah.
You say as soon as possible, but you've also mentioned late rehab, and I'm sure you do get patients that are referred to you very late. So
Yeah.
what is the impact of starting rehab at a very delayed stage?
They develop complication which can be avoided. So, for example, stroke. Yeah, they go back home and the carers are not aware how to take care of them, so they end up being just left on the bed. They develop pneumonia, so they readmit again. So the vicious cycle just continue. And worst of all, the recovery is not restored. So they get tense, they get contractures, and by the time they come to us, by right, they should be able to improve, but because there's already complication that sets in that hinders their recovery.
Dr. Lydia, who is typically your team to provide service to the patients?
Sorry, I didn't get that.
Who's typically in the team of rehabilitation medicine?
Okay. All right. So we have got the physician, the rehab doctors. We usually would be to lead the multidisciplinary team and focus on coordinating the team members. So we will address all the medical issues of the patient. For example, their risk factors. We treat the underlying condition. We treat the potential condition, like, for example, the pain, spasticity. And then we have got the rehab nurses. They will look into the nursing aspect of the patient. They manage the bladder and the bowel. We have got the physiotherapists who look into the physical aspect. They will be the one who's training the patient to redo back the muscle training, standing, verticalization, walking. We have got the occupational therapists who would train the patient again on activities of daily living, look into the functional aspect of the patient, and not forgetting the speech language therapies. They will deal with the swallowing and the speech, the prosthetic and orthotics, if let's say we need orthosis. Yeah, so that is the core team members for the rehabilitation. But we also include the referring doctors. For example, if George refers to me, then he will be inside the team where we will update him on the progress of the patient.
All right.
Because he deserves to know.
He deserves to know, indeed. And we're looking at a big team, and really, that sounds very, very comprehensive to cover all the functional aspects of the patient's condition. We'll go for a quick break first. I'm speaking to Dr. George Lee, consultant urologist, for our Doctor in the House segment today. We're discussing rehab medicine, along with Dr. Lydia Abdul Latif, Chief Medical Officer from ReGen Rehab Hospitals. If you have any questions, send them in now. WhatsApp us at 018-789-8899 or tweet us at BFM Radio. We'll get to them after this break. BFM 89.9. Good afternoon. Welcome back to Health and Living. It's our Doctor in House segment. We have on the line Dr. George Lee, consultant urologist, as well as Dr. Lydia Abdul Latif, Chief Medical Officer from ReGen Rehab Hospital. We're talking about the role of rehabilitation medicine in helping patients to regain function. And we're talking about a whole host of various conditions, including injuries, surgeries for conditions like heart disease. We're talking about disabling medical conditions as well. If you have questions, do send them over. WhatsApp us at 018-789-8899 or tweet us at BFM Radio. Dr. Lydia, we've talked mostly using stroke as an example, and that's valid. Stroke is a non-communicable condition related to our high rates of things like diabetes and hypertension. It's on the rise in Malaysia. It's very debilitating and disabling. But another thing you mentioned that I found very interesting is cancer rehabilitation. Dr. Lydia, what does cancer rehab look like?
Okay, so cancer rehab, just like in any other area of rehabilitation, is still aimed at restoring function. Okay, because we know that a patient who has been diagnosed cancer, they are in different stages of the disease. So depending on which stage they are in, there will be a stage where they are still requiring active rehabilitation because things like they may be deconditioned because of the cancer treatment itself, or they may lose a function because of the cancer itself. For example, they may have a spinal cord mats that leads them to having a weakness, or they may have neurogenic bladder and bowel, or they may have pain, so these are the reason why they actually would still require rehabilitation. So there is a difference between the stage where they need active rehabilitation and the stage that they just need palliation and nursing care. So we try to see those who still requires active rehabilitation.
Okay, all right. How and I guess overall, looking at each individual patient that is in front of you, how do you determine and how do you help them set the expectations? In terms of
so we have got to.
Sorry, in terms not only outcomes, I know you've said it's goal driven, it's outcome driven, but also how long should they expect their rehab journey to take?
Okay. All right, so that's a very important and pertinent question, yeah. So going back to our assessment. So, like I said, we will do a very comprehensive assessment whereby we look at the pathology of the patient because we need to prognosticate. And when we prognosticate, we have got to give the closest to what we feel that suits the patient. So we cannot give them unrealistic kind of prognostication. So for example, a patient who has got a stroke, it's very important that they want to know whether they can walk in 3 months' time, or a patient who suffers from spinal cord injury, whether they are ever going to walk again. So we need to know the pathology of the condition. We need to look at the severity of the condition, and like what George said earlier, the general well-being of the patient, because that also contributes to their overall recovery aspect of the patient. So that is how you would address the patient. From there, you would then anticipate their impairment. You would know and list down all their impairments, and then you would look at what are the impairments that you can work first. What are the impairments that you may want to work a bit later? So, for example, a patient who had a cardiac bypass, and following the cardiac bypass, they developed stroke as a complication. So they have got multiple impairment. They have got reduced in endurance. At the same time, they have got physical impairment. So are you going to do the cardiac rehab first to do the endurance, or are you going to start doing the stroke rehab? So this is where we need to judge based on the patient. So this is where you need to look at the medical aspect of the patient, the physical aspect of the patient, and you need to decide what is the priority that you need to do for the patient.
Lydia, can I ask you, I mean, obviously, all these are quite a long-drawn process. How much family involvement are taking place with rehabilitative medicine?
Okay. Yeah. Okay, that's a very good question, because in rehab, family is actually very important. They serve as the support for the patient. In fact, one of the things that we use to prognosticate their recovery is actually family support. If they have got family support, their prognosis for recovery, for example, not just for stroke, for any other condition, would be good. So what we do is what we always tell them is we're holding their hands. We take them through the journey, the phases of rehabilitation that the patient is going through. So this is the first thing that we sit down with the family. We tell them about the condition. We tell them about the expectation. We tell them what they will be going through, and this really helps the family and the carer. They know what to expect. So this is very important, communication and putting laying down the cards on the table for them.
Mm-hmm. How much of the rehab therapy is continued beyond the hospital setting, Dr. Lydia?
Okay, so it depends also at what level they are being discharged. So for example, inpatient active rehabilitation is very important. So patient who has undergone an active inpatient rehab with us, by the time we discharge them, they would already be at certain level of function. So they may just need maintenance kind of rehabilitation. So this can be as simple as twice session of 30 minutes a day. or they may not have undergone an active rehabilitation, so they are still in an active phase, but they are not able to come in as inpatient due to many factors. So they may need to do a little bit more, longer session at home. So this is guided by, again, their severity and their phase and what is their goal.
All right. We have a question here from Russell who wants to know whether rehab treatment is available for eye conditions like glaucoma.
Okay, so there is this thing called the low vision rehabilitation, right? It is part of a rehabilitation to get them to function back, but this is very much done by the eye doctor, the ophthalmologist.
All right. So it's part of your treatment, your management with your ophthalmologist then.
Yes.
All right. Coming back to the whole process of rehab. And, you're also talking about things like maintenance, something that you can do at home to complement what your therapist has taken you through in the clinical setting. Let's talk about cost, Dr. Lydia, because we're talking about a very, very long drawn process. In conditions like stroke or even a bypass and those kinds of treatments, there's already been a huge medical bill incurred. How much more does rehab, add to that bill?
Okay, so actually, rehab is the cheapest portion of the medical treatment. Okay, so one of the reasons we do rehabilitation early is to prevent the dependency of doing rehab for a long time. We don't believe that rehabilitation should continue forever. All right, so one of the reasons that we want to do rehabilitation is so that they can restore their function much faster. And it is evidence that, for example, a stroke patient, spinal cord injury patient, if they do get the intensive active rehab that they deserve to get, this will reduce their need of a long-term dependency. You can see this in patients with low back pain, for example. It's like a vicious cycle. Low back pain is one of the most disabling condition and is one of the most commonest cause of MC, for in the workforce.
Yes.
So if they get proper rehabilitation, then you can really cut their dependency of coming to see the therapy for a long time. So in a way, it is very cost effective. And we can actually return them back to the working force much faster. So I would like to correct that, it's not like rehab takes forever to be done.
Yeah, contrary to common belief that because it involves so many healthcare profession, it's so long drawn, it's just going to be very costly. However, it's not. Obviously, there is some cost involved, and in the government and also private setting, and then who foot the bill under that circumstance? I mean,
Okay, so there are currently in our current health funding, rehab is being financed either is out of pocket. Insurance, not all insurance covers rehab yet. So this is where we need to start talking to the insurance people to start looking at the needs of funding for rehabilitation. And this has been mandated by WHO, the World Health Organization. They actually have this paper that's called Call for Action 2030, whereby WHO requires or requests country members to relook again at the health financing situation of each country and to strengthen the component that finance rehabilitation, because we are in a very timely position to scale up our rehabilitation services. So this is where we really need to look into, we need to work together to try to strengthen so that we can actually scale up our rehab services, which is long denied, and there's a lot of unmet needs for rehabilitation.
Just very quickly, Dr. Lydia, what is the distribution of rehab physicians and the kinds of trained specialists that you would need across our country, especially in the public sector?
Okay, so at this present time, we have about 100 rehabilitation physician, and if we look at our population, it is estimated that you need about 6 rehabilitation per million population. And at present time, in terms of the public delivery of the public rehab services, it is confined to just the major general hospital. All right, and of course that is already saturated in the urban area, like in Klang Valley we have got we have got it covered, but in other states, there is still lacking in terms of the facilities and the human resource to deliver good quality rehabilitation.
All right. And I note we do have one public hospital devoted to rehab, and that's the Hospital Rehabilitasi Cheras. Is that right?
That's right. Yes. That is that's our national rehabilitation hospital.
But one is clearly not enough, and it's in the Klang Valley, as you said.
Because you need to look at the that will serve the central needs, but you also need to look at the southern and the northern region as well as the East Malaysia.
Absolutely. We're running out of time,
Okay.
but just very briefly, Dr. Lydia, perhaps a message on what can we do to improve access, to strengthen the delivery of rehab medicine to the patients who need it the most.
Okay, so I think it is very important for us to improve the integration of rehabilitation in the health sectors. That means we need to strengthen the integration. We need to try to incorporate rehabilitation in the universal health coverage. We need to continue to develop strong multidisciplinary rehab workforce. We need to continuously train so that we can deliver good rehabilitation. So there's always the need for building more research capacity in terms of what is the available robust evidence of rehabilitation. So these are the 4 key points that I would like to send a message to.
George?
Well, it's been certainly an eye-opening session here today to hear about the extensive work and the number of pathology it covers. I think rehab medicine is probably one of the few kind of like a medical field that it's not really always in the limelight. But
it is, but it's actually one of the top 20 future medical specialty in need in America. You can check that out.
All some heroes.
Unsung heroes, that's right. And it's really important for all of us to take note of its role in our own recovery and therapy as well. Thank you so much for joining me today, Dr. George Lee, of course, consultant urologist, and Dr. Lydia Abdul Latif, Chief Medical Officer from ReGen Rehab Hospital. We've been discussing rehabilitation medicine. You've been listening to Health and Living on the Bigger Picture, BFM 89.9.
Thank you for listening to this podcast. To find more great interviews, go to bfm.my or find us on iTunes. BFM 89.9, the business station.